Welcome to TraumaCast. It's like a podcast, but about trauma. Listen and learn from our team about current trends, new research, and continuing performance improvement efforts. This education is available for CNEs. Successful completion includes watching or listening to the entire session and completion of the attestation and evaluation. The link for the attestation and evaluation is located at the end of this video. We hope you enjoy, and please let us know what you think. All right, welcome to another TraumaCast. We are going to talk about the basics. We're going to talk about our trauma activation, the various activations that we have, the different levels who respond, and how we can manage the number of people that respond in the trauma bay. Today, we have our lovely trauma team. We have Liz and Jen. If you two, Jen, and starting from Jen, if you would like to introduce yourself to our viewers.
Hi, I'm Jen Fritzine. I am the Trauma and Burn Program Manager. Liz, all you.
Yep, I'm Liz Bible. I am the Trauma and Burn PI coordinator, as well as one of the nurse practitioners on the team.
Thank you, and welcome everybody to our 8th TraumaCast. And we're going to go straight into the topic. And Jen, do you think you can start on talking about the 3 different trauma activation levels and the difference between those 3?
Sure. I think the easiest one to understand is the highest level, which is our trauma stat attending. Our trauma stat attending level really looks at certain criteria, and those criteria are all really physiologic based for the most part. It is hypotension, patients who can't breathe, patients who are not maintaining, have a GCS less than 8. Those are pretty obvious sick kids that require a full complement of our trauma team to be in the room. To manage their care and to make sure they're stable, but B, to make sure that if there is a decision for surgery, that we can get them up to the OR fast. There are a couple mechanisms of injury. I think one mechanism of injury that constitute a trauma stat attending, and that would be a penetrating injury to the head, neck, torso, or like upper groin area. And again, that comes down to having a complement in the room in order to quickly expedite a patient to the OR. So that's the easiest one, trauma stat attending. Trauma stat and trauma transfers are almost the same thing. The activation criteria is the same, but what makes one patient a trauma stat and one patient a trauma transfer is how they come in our door. If they come in from the field from EMS, we don't really know anything about them. So they're a trauma stat. And a trauma stat, because we don't know anything about them, really kind of takes a bigger team than a trauma transfer. A trauma transfer is going to come from an outside hospital. At an outside hospital, they've been evaluated, they've been assessed, they've gotten some treatment, and hopefully they've been stabilized. And so you can have a smaller team to basically bring that patient in, make sure there's no missed injuries, make sure we don't have to go to the OR. If there's any missing labs that are or imaging that hasn't been done, we can do that, recognize that quick, and it kind of moves them through the system. As far as the criteria for a trauma stat and trauma transfer, there's some anatomy that goes into that, like a subdural epidural diagnosed at an outside hospital. I'm pulling it up so I can be accurate. If you look at mechanism of injury, that might be a car crash of a restrained patient more than 40 miles per hour, or a car crash with an unrestrained patient more than 20 miles per hour to make you meet that. All of these are what I'm looking at right now. All of these criteria are located in our trauma app, the CN Trauma app. If you don't have it, you can get it at your local app store for both Google Play and Apple. That's a nice little plug, isn't it? But if you go under trauma activation, under criteria, you can see we have it divided out by system. So airway, if they're intubated in an outside hospital, but they're stable with their ET tube and with the ventilator, then come in as a trauma stat or trauma transfer. If they have early signs of shock, trauma stat or trauma transfer. GCS of 9 to 14. Open depressed skull fracture, head laceration with active bleeding, Positive neurologic symptoms, that's numbness or tingling in the extremities. It's not necessarily I can't move. Abdominal tenderness after a blunt injury or a seatbelt sign, et cetera, burns greater than 25%. So anyway, you can see those criteria listed. And these are the criteria that the MCOs are using when they get a call either from an outside hospital or EMS to make that decision. Liz, did I forget anything?
Well, I just wanted to, a couple of nuances to kind of piggyback on those. That was a really good summary. So there is also I guess a spot on the activation criteria list for physician discretion. So you get the story from EMS and something just doesn't sound right. Okay, I'm going to go ahead and call a trauma stat or upgrade to a trauma stat attending. So that was number one. And then number two is that, we'll probably get into this a little bit more, but you can always upgrade the trauma. So a patient, get a call from the field that there's a GCS of 10 and they enter the trauma bay and wow, gosh, the GCS is majorly dropped. Their waxing and waning GCS is more like a 4. We can certainly upgrade to a trauma stat attending. And I'm sure we'll talk a little bit more about that.
Let's just to kind of keep going on it. Sorry, Joanna, if we're going off track.
Please.
But those trauma transfers, I think, are one population that we do upgrade quite a bit because you get a call from the outside hospital. They sound like they've been stabilized. The patient gets here and they're hypotensive, or we're having trouble ventilating, or there's just something else going on that we need a bigger complement of team. And so taking that trauma transfer and upgrading it to a trauma stat attending is something that's actually done quite a bit and has been. I think our teams are pretty good about doing it too. I think the biggest thing is when they do it to make sure they officially upgrade. And what we mean by officially upgrade is you don't just pick up the phone to the ICU or the attending surgeon and say, hey, can you get down here? But officially you need to go through ECIC, and so another page can go out that says upgrade trauma stat attending. And so everybody who truly needs to know now is aware.
That's great. And I think that's so helpful to understand because there's so many pages that go out, right? Whether it's trauma stat or trauma stat attending and then trauma transfer. And the pages go out hospital wide because we have so many team members coming in to assist with the care of this patient. Jen, do you mind kind of expanding on who responds to a trauma stat versus who responds to a trauma stat attending?
Absolutely. And to be honest with you, I just updated in that lovely app. And so you can go to, there's actually, if you go in the trauma activation section, yet again, the first thing you'll see is criteria on the upper left. The second thing you'll see is CR staffing. And that very clearly gives you a table telling you who is supposed to be at every level. And so a trauma stat attending is where we have the most people. And how it differs from just a regular trauma stat is that a trauma stat attending, I want a surgical attending there. And a surgical attending for this purposes is either one of our attending surgeons, or it could be one of our fellows. Currently, well, we always have 2 fellows. With the colorectal team, a lot of times we'll have a third fellow that can go through rotation. But those fellows, because they are board eligible general surgeons, can count as attending. So the reason we need that attending surgeon there is if we do need surgery, you have to have an attending level or board eligible surgeon making that decision for surgery. And then, of course, we'll have our surgical coordinator, like always, your ED attending or fellow, our resident or NP to do the assessment. We definitely want our PICU attending or fellow to be at the bedside if it's a trauma stat attending. They're fabulous to have down there for a couple reasons, several reasons, but really 3 I like to identify is 1, if you want a PICU bed and you want a PICU bed fast, get a PICU fellow or attending down there. They know how to get the bed. That's reason 1. Reason 2, if we start doing CPR, they are awesome at guiding CPR and coaching people through CPR. They can put their finger on the pulse. They can also, in those cases, possibly help us get a line, a femoral line if we're having trouble. And then the third reason I love to have a PICU attending there there's a third reason. And I'm blanking on it right now, but I think the two I gave you were really good. They often have a lot of suggestions just with care moving forward. You know, if we start an epi drip, they're the ones that are going to have to continue this, and they can give some suggestions to the team. And then, of course, we have our full complement of nurses with our 4 roles, plus or minus a pharmacist in that med role. You'll have your social worker, radiology, But your 2 extra people are your surgical attending and your PICU fellow or attending. A trauma stat, you're going to have your regular team. And I think everybody knows that regular team. Your surgical coordinator, who's our 4th year fellow, our NP or surgery resident who can do the assessment, your ED attending or fellow, your anesthesiologist who will intubate if we need to or manage the airway, your complement of nurses, social work, Now, where it gets interesting is trauma transfer, because remember, these kids have been seen in an outside hospital. They've been stabilized. For the most part, a lot of them come with their imaging done, and they come with all their labs drawn. So our job really is to get in and get out. Get in, get an assessment done, make sure they didn't miss anything, look to see if we need any other testing, and then decide what to do with them. And so technically, we can have a much smaller team. You still want both your surgeons, your surgeon coordinator, your resident, your NP. You'll definitely want an ED attending or fellow. But for nurses, you could really downsize that team and just put 2 in there and, you know, have somebody document, have somebody do bedside care. It's really not, for the most part, not that much harder or busy than a sick ED level 2 admission. Radiology does not come, so there will not be any x-ray. So if you do need an x-ray to trauma transfer, we would have to call them. Now, that's why if you have a trauma transfer and you need to upgrade to a trauma set attending, you really should just put that page out, because anesthesia needs to now come. They won't be there for a trauma transfer. Radiology needs to come. They won't be there. Your attending surgeon, your PICU doc, and you don't want somebody just making 4 phone calls. Make the 1 phone call and have it go out.
Okay, great. Thank you for that explanation of who responds to our different activations. Can you kind of go through on how we can find a resource for these roles and what their responsibilities are during trauma activations? Jen?
Sure. We tried really hard to just kind of break it down to really like key roles. Obviously, in a trauma, you could be asked to do a lot of things within your scope of practice, but we tried to, for each role, tried to kind of put 3 to 5 things, I guess, for each role to kind of give people direction on what they're supposed to do. And again, I'm going to go back to referring you to the CN Trauma app. If you go under trauma activation, I've already talked about the first tab, the second tab, it is now the 3rd tab, and it is titled Team Roles. And if you go, they're color coded. It tells you what all roles are expected to do, like don PPE, get your sticker, introduce yourself, and then it breaks it down for each role in the code room and kind of just gives you the down and dirty about the expectations that you're going to be asked to fulfill. And like I said, I definitely want to put the little caveat that you may be asked to do something outside of this, what's written, but obviously not outside your scope of practice.
Thank you so much. And so we went over like who's necessary within the trauma set attending, especially since there are one of our sicker patients coming through. Liz, do you think you can, what are additional ancillary members that we've seen come through the trauma bay? That's not quite the core team, but those who kind of like respond, who have like responsibilities, but don't really have a role. What have we seen in the past?
Well, certainly if the family needs the support of an interpreter, that could be one person. I'm not sure if they're on that core team list, but that's one that just comes to mind. And then consults as well. So if the patient has a neurosurgical concern, if the patient has an orthopedic concern, we will call a member of that team, and the expectation is that team member arrives for assessing the patient within 30 minutes. And oftentimes they're there much, much quicker. So those could be other folks that you may see, again, liaisons from some of our surgical specialty consultation departments. So again, orthopedics, neurosurge, they most specifically come to mind. And oh, chaplain,
Yeah.
absolutely.
Yeah.
Chaplain, yep, for sure, for sure. Certainly, you know, it's wonderful to have child life at the bedside as well. But those are the folks that come to mind. And in addition, you know, trainees too. People have to have to orient, but we can talk about some strategies when there are multiple folks who need to orient or learn from some of these sick patients.
Yeah, I would also say some of our really sick patients, you know, if they're going to do a kind of an OR procedure downstairs, like open a chest, we might invite a surgical tech to come down and help also. And they would not necessarily be on the list.
Yes, and they're just such a critical member of our team that we don't really like use a lot, right? So we don't think of like in the forefront of our mind, but when they're there, they're like so neat. It's so important that we think of them. And so I guess kind of shifting, because we're talking about trauma stat attendings and all the members that come down to those calls. Jen, in your experience, I guess, what kind of injuries do we see more of when we have an onslaught, like just an increased number of people responding to our activations?
Trauma set attendings, obviously a lot more people come out of the woodwork and come down, and you get a lot of people standing in the back who, you know, want to quote unquote learn or want to be there just in case there's other hands that are needed. But even just a basic trauma stat attending, I think people have gotten pretty good about just sticking to the roles. It's when it gets to be trauma stat attending, gunshot wound or stab wound to chest, abdomen, neck, you know, those places where these kids could be incredibly unstable. And then if you add the word CPR in progress, the number of people who come to the code room even goes up more. Gosh, I think the last patient or one of the last patients over the last couple months we've had that was a trauma stat attending gunshot wound, CPR in progress. I want to say we counted what, like 32 or 36 people that were in the room within camera view. And I can guarantee you it did not take 32 or 36 people to take care of this child.
And kind of going along that vein, what for those patients, because they are such a high acute patients, especially when they're trauma stat attending, penetrating trauma, whether that's a GSW or a stabbing, and CPR in progress, what are our main goals within the first 2 minutes? What should we be doing and focusing our attention on?
You want to take it, Liz?
Sure. So first thing we need to do is confirm the pre-hospital downtime. We need a good idea or we need an actual number from the pre-hospital providers about how long CPR has been going on. It's a very different story. The patient loses pulses on their way into the hospital versus CPR in progress for 30 minutes. So the longer that we go with CPR, we know kind of, unfortunately, what that outcome is going to be. So number one, we want to establish downtime. Number two, we really need to take a definitive pause and look for signs of life. Once we do that, then we look for reversible causes. If it's penetrating trauma, could this be a tension pneumothorax? Could this be tamponade? So that surgical decision maker in the room, that surgical coordinator, that fellow, that attending really needs to focus and to get into that patient's chest quickly. Performing a needle thoracostomy quickly, a finger thoracostomy quickly, and then making that decision again based on what that yields about next steps forward. If the chest needs to be opened, what volume has the patient gotten, et cetera. So there are a lot of very quick, critical decisions that have to be made. And it's really, really tough when there's a ton of distraction in the room. So that surgical provider needs immediate access to the patient and really just a chance to think and to go through that algorithm in his or her head.
Yeah, and I agree with everything Liv said, and I think it starts in that pre-arrival phase. And when you're talking about number of people in the room and who should be in there, the more people that are in the room, the louder the room, the more chaotic the room, the more hands you have trying to set stuff up, so it's easy to lose track of who's doing what. And so from a pre-arrival standpoint, that's something that the leadership and the team needs to look at is everybody, this is going to be a busy, chaotic room no matter what. And so trying to decrease the chaos in the pre-arrival piece is actually critical, because you're already decreasing the chaos by getting people out of there. People can now have, it decreases the side conversations, because in that pre-arrival piece, we need to, like Liz said, know what the downtime is. If they tell us there's a downtime of 10 minutes, your leadership is going to now talk to the team about what the priorities of care are going to be. Again, look for signs of life. Do we have bloods? Whoever's assigned to the Belmont, which may be an extra role at that point, prime blood. Or EMS said they're coming in with whole blood. Well, what does that mean for our team? Go ahead, still prime the Belmont. We'll finish the whole blood, we'll move on. But those are discussions that are happening. The less people are in the room, the better those conversations are going to be, and the more pointed we can be to different people and who their roles are. One of the roles that we would really like to get out of that room, we being the trauma team as a whole, is this whole concept of a CPR line. And I know people might think that's crazy because a kid's coming in CPR in progress and we only do CPR for 2 minutes at a time and then you switch out. So here, listen to my explanation. It does make sense, I promise. If you have a CPR line, that's usually 4 extra people in the room that are standing on the side of the room and can get in the way of getting in the Pyxis, getting x-ray to the patient, what have you. The patient's going to roll in. If they have had CPR longer than 15 minutes, their chances of survival are less than 1%. And so if we know a child has had CPR for greater than 15 minutes, the likelihood is that we may not work long. And if there's no response, no signs of life, this may be over quick and you don't need those 4 people. But let's say it's under 15 minutes, or we think it's under 15 minutes. EMS comes in, they clarify with us that it's been under 15 minutes. So somebody does take over CPR. But like Liz said, one of the priorities is reversing whatever's causing them to be arresting. And to reverse that, our surgeon a lot of times has to take a scalpel and get into the chest. Well, you can't be doing CPR when he or she has a scalpel in her hand, opening a chest or doing a finger thoracostomy. She's going to tell you to wait. So you may start CPR for a few seconds. That surgical coordinator is going to tell you to wait. They're going to do what they have to do. Once they're in that chest, they're going to do internal compressions if it's non-reversible. And so the amount of time we need external CPR is actually very low. And that person doing CPR may be in the way of doing an actual life-saving procedure. So all those people that have lined up, what we're saying now is 2 people. And if you're one of those 2 people and you see that they're opening the chest, guess what? You can self-excuse yourself because that CPR line is no longer going to be needed, because we're going to do internal until we go to the operating room or until they've decided. And just so people also know that when we do go to an open thoracotomy, the chances of survival are less than 5%. And I just think it's always important for people to realize we've done more of those this year than I can ever remember. So that's how it goes to crowding. I think we're kind of going on tangents, but they're good tangents.
I like it. Thank you. I think it's really necessary to have that explanation, because it's a concept that's been like drilled into our heads, right? If they're in CPR progress, the only thing you need to do is continue CPR, right? Because that's how they're going to get their circulation. But knowing that there are things that we need to do that is more pertinent to assess signs for life, right? And then if needed, to open up the chest, to do the finger thoracostomy and see if there are reversible causes. it's a new concept that we have to
Yeah.
start
It's-
learning and to be
it's-
able to
it's-
kind of like anticipate.
Yeah, it's the difference between PALS and ATLS.
Right.
And for many, many years, most of those patients that were coming into our code room in arrest were medical patients. And you're right, Joanna, medical patients, you are going to do CPR. You are going to need
Yeah.
that line because the causes are different.
Right.
But when hemorrhage is your cause or a head injury is your cause, it's very different than that medical arrest, in which CPR, and there's literature, if people want it, I'm happy to send it to you. There's literature out there that basically says CPR sometimes is going to get in the way, and it's going to be able to delay life-saving care in that trauma patient. And so for everybody listening, remember, we are talking about that trauma patient, not the medical patient in the code room.
And it's important to delineate that, because care is going to be different, and what the surgeon is going to anticipate, it's going to be very different from what the medical provider is going to want to do, right? So depending on what the cause is. And so I think it's a new concept. It's going to take a while for it to sink in and to marinate and to be able to anticipate that. But I think it's very important and
Yep.
critical that we just continue to repeat it.
We're updating the penetrating trauma poster for the room setup. And on that poster, it's going to say under the charge nurse role and the NAL role is to make sure your CPR line is less than 2. And so we're going to get some reminders out there on resources that we know people use.
Yeah, I think that's great, because like the penetrating trauma poster has been used so much in that room and has been such a great resource for everybody. Just to going back into a bit on crowding. Liz, can you explain a little bit on what your experiences and what you have observed, some of the negative effects when we do have more people in the code bay than needed, and like how that affects the care of the patient?
Oh yeah, I think, again, especially if there's a critical procedure that needs to be done, like a chest tube place, if there are 3 individuals between the surgeon and the patient, that's gonna slow things down. So again, you have to, the surgeon needs to have access to the patient to perform life saving interventions. And number 2, if you're the one that's assessing the patient, it's really hard to hear breath sounds when there are extra people talking, when there's so much extra noise in the room. So, and you want to be, obviously you want to make sure that that your assessment, that ATLS assessment, is being heard by the charge nurse and you're not constantly repeating yourself. So you really want to be able to concentrate. And I think that's really something, again, the more excitement, the more energy in the room, it really takes away from people concentrating and remembering these critical algorithms and the H's and the T's and, what are some reversible signs. So, I really think that, as calm as we can have the room with as little noise as possible is really best for everyone performing optimally.
Yeah, we've seen delays in care based on crowd. Some that come to mind is we've had delays in getting x-ray to the bedside because there's been so many people for x-ray to get around. We've had people, the surgeon asking for supplies, equipment, and it's been so chaotic in the room that nobody heard. Or if they did, they all thought somebody else was getting it, and so it delayed having procedures done. So, it really can impact care. And, okay, so it takes an extra 5 minutes to get radiology to the bedside, but it's a hemorrhaging child. And 5 minutes is a lot of blood loss. And so those are really the things that we're watching, that I'm going to go back to the CPR line, having to explain to people in the moment to back off and stop CPR takes a minute away from that surgeon getting that scalpel to the chest. And so that crowd can make a difference. That extra person, that little side whisper that you have in the back can make a huge difference. We've had blood being delivered, when blood bank comes down with the cooler, it's gotten lost in the shuffle because somebody came down and they said blood's here and nobody could hear, and then they put it down and nobody saw it. And so you had 20 people walking around the cooler of blood while everybody was shouting, "Where's more blood?" So you can see how it really can impact the outcomes of what we do. It's not trivial to have having too many people in the room.
Yeah, it was such an interesting and stark picture when we did a video review of one of our 3-year-old that came in not too long ago who was a GSW, and there were just the child was so small, right? But there were so many people around them they were all trying to just get that little 1 inch to do their task or to do whatever intervention they had to do. But because there were so many people, it was it's so hard to get in, right? But if we think about it, a lot of our patients are that much smaller, and real estate is definitely
It's
not,
precious.
we don't have a lot. Very precious real estate. So what I just want to go into, now that we've talked about the crowding and what it can affect and how it can affect patient care, let's talk about what we're trying to do, or some protocol adjustments, little things that we want to do so that we can address the crowding issue as well as help with the patient outcome, while also addressing the need for training, the need for people to be able to watch and learn from these events. Jen, can you talk about some of our changes that are happening?
Yeah, so as we have seen crowding become an issue, especially with these really sick kids, we put together a multidisciplinary team and we've met and we really kind of talked through some of the issues with crowding. We talked about who really needs to be there. The fact that, really sick kids may take a couple extra people in the room. For instance, if we're going to use the Belmont, you need an extra nurse, you just assign them to the Belmont. That makes sense. If you have a patient that is Spanish speaking, if you're trying to assess their GCS, you need somebody to be able to talk to them. And so, we've kind of looked at all those things. It was actually a very good meeting. And some of the other things we came up with, there was the idea of having somebody assigned to do crowd control. Now, we have not officially rolled this out. It's coming to an ER near you soon. But we did talk to ER nursing leadership and, everybody kind of agreed, as did they, that the ED charge nurse might be that best person to help determine who needs to go. And be able to be the one that is kind of given the authority to say, you're really not needed. I need you to leave the room. That's a hard thing to do. And not everybody pays attention to you, but this is somebody who has a leadership role and can help. We are in process of setting up a viewing room because one of the things that came out is we do have a lot of trainees and they do need to learn. Now this isn't the person that's orienting to nurse left with the nurse. This is a person, a resident, or somebody who it's their second day as a nurse and they just want to see, these are the people that are standing in the back of the room. If you've ever stood in the back of the room during a trauma activation with that whole team standing around, like Joanna said, that bed with that little bitty patient, you can't see anything and you really can't hear, and it's hard to tell what's going on. Well, we have video cameras all over that room. And so we have a computer now in that EMS room that's right inside the ambulance doors. And it's hooked up to Ocularis. And so people are going to be able to sign in with the general sign in and be able to pull up Ocularis, which is the name of the video company we use. And they're going to be able to stand there and they're going to be able to see real time what's happening and hear it. And they're going to see it from over the bed. So they'll be able to see the patient. You really get a good idea of the assessment. They're going to be able to see the whole room, both from the front and the back. And so not only will they see from 3 different vantage points, they'll be able to hear. And I'm going to be honest with you, I would prefer, I can watch all of this from my office or my computer. I am able to absorb and understand more of what's happening watching it from the computer from Ocularis than I can when I'm standing in the back of the room. And so we really think that that will help augment learning versus having extra people standing back there. Again, when you're standing back there as an extra person, a lot of times there's a little side conversation, even if they're quiet, it makes a difference. And we also need to think about that's where the family is. And we don't have another place to put family. And so to have our team of people just stalking around, watching, while this is the most tragic day they've ever had, is kind of intrusive. And so really being able to utilize this room, and we're hoping that the ER charge nurse as the crowd control person can really help move people to that room. We are setting up video reviews specifically for nurses, and we've done it with one patient. And so hopefully, you know, we can show crowding and we can show roles, and we can help just continually improve people's efficiency through doing that. And then eventually we just want to keep talking about crowding with people, because we want to get to be a culture of self-assessment, to where you're in that room, nobody put a sticker that says nurse left or charge nurse or NAL or whatever on, you're just there with no sticker, and to be able to self-assess that, you know, I don't think they really need me. They have a lot of competent, qualified people in this room, and I'm going to go ahead and step out. And now remember, if you're one of those people and you still want to watch, go in the EMS room, and the team you'll be able to hear, they could say, I need somebody from the EMS room. And wouldn't that be cool to get a culture where we could call somebody from that room in?
Yeah,
Just, you know, we need another set of hands. So
yeah.
those are the things we're working on. I'm hoping to have that computer up and going soon. I thought it was going to be really easy, but it's really hard to get a general login on the computer anymore. So I'm waiting for IT to get me a general login, and then it'll go live.
I mean, those are great. I mean, I think because it's it's something we don't see a lot. And so when a patient does come in with these kind of injuries, we're doing procedures that we don't see. I think there is a lot more, I guess, attention that we want to be able to observe it, to be able to be part of this. But I think, as you said, like, to be able to do that self-assessment, to say, am I really needed? Am I superfluous? Am I like, am I making a difference? Like, to be able to say that and just step out even to the hallway. If somebody needs you, they'll call you, or even to the viewing room. That would be a great help in decreasing the amount of people in the code bay with these really sick patients. Thank you guys so much. I think this is such an important topic. It's not something that we would really like talk about necessarily. It's not something that's really top of mind for everybody. But if anybody's responded to any of these trauma stat attendings, when there are, especially during the day shifts, like when there's so much more staff around, I think we've all seen a case where it's like so chaotic that we can't hear anything, and the charge doc is constantly saying, I can't hear anything, we need to be quiet. And then we've all seen the one that's just run so smoothly, where people are clicking and the noise level's down, and you know, the teamwork is great. So I really think this is a topic that is something that will continue to be talked about throughout in the future. But I do thank you guys for coming on to talk about
Juliana,
this with me.
before we're done, can I reverse the question to you?
Yeah.
So Joanna, you've worked in our PICU as a PICU nurse, and then you were a crisis nurse. And so you have also not only been to trauma activations, but you've been to medical codes all over the hospital, correct?
Yes.
And so one of the things that, you know, I feel like this crowding talk is all about what's happening in the code room, and it's very ED centric. But the reason I'm bringing this up is because I don't think trauma is the only thing that draws a crowd.
Yeah,
And, you know, for a medical code, you may not have a viewing room, you may not have somebody doing crowd control, but as we try to really push to a culture of self-assessment for looking at your need to be here, I think, you know, there is some commonality with what the floor nurses and what the ICU nurses can experience in other types of emergent situations. So I just kind of wanted to make sure that we didn't come off totally as ER centric here.
Yeah, for sure. Like, especially if you have a code blue on the floor, or if we have a active code in the PICU, everybody comes out of the woodworks, all peoples.
No, and
And-
to put that straight, you do need extra help. I get it.
Yeah,
Yeah,
and
yeah.
it's great when you do, but it does become very confusing to know, especially since you don't know all of your team members, because they are coming from different parts of departments, different units, to understand who the core team members are. And the floor does a great job, and ICU does a great is doing a great job with like putting stickers, kind of what we do in the code bay, on who the roles are. But because there's such a large amount of people responding, it's hard to know who the leader is and who's doing what. And I think it is very important as we can observe as an outsider and to understand what is needed and to be able to say, I'm going to step back. I'm not going to add to the chaos if you're not a core member of that of the responding team. And of course, there are hands that are needed during these times, but it's not, again, it's something that you would have to.
It's not 36 people.
Yeah. Yes. Assess the situation, see if they need help. If not, I mean, and then there are those patients that get left behind, right? Because everybody's responding to the code or to the trauma. What about the other patients that need your attention as well? So sometimes that's the real hero.
Right, that's where the help should be focused, right?
Yeah, the one who stays behind to watch everybody else.
Yeah.
Yes, all the other patients that need your care. So
Right,
yeah.
thank you everybody for listening to us.
Yes, thank you for your time, and thank you ladies for coming on to talk about this topic. And we hope that we can continue our education with future TraumaCast coming soon to YouTube near you. Thank you.